are not going to be only benefits coming to Eternal Heart. I call it the halo effect. When you create a nationwide, a popular program, almost every center will improve. But I do believe that just because they have the best structure at the moment, the best on-call structure, the way we have created an emergency bypass, it is easily, I can tell you, there is no model in entire India, something like Rahat. In fact, I can tell you there is none like this in the world also, because I have done most telemedicine work. It is the best of it which is here. So please support it, use it, and I truly believe that this will help save more lives from heart attack than any other initiative being done in the country.
Yeah. So we invite comments and queries from the general physicians, and I would like to ask Dr. Khader and Dr. Alok Mathur to, as a physician, because these are the leading physicians in our hospital, they can give their inputs.
I think awareness part is very important amongst physicians. And centers, what you are planning, 24-hour service, if it is not there at the center, how a patient can be sent to the primary center? 24 hours service at the center, what you have planned. That is, I think, most important, because if they have no 24-hour service over there of physician, then it's very difficult to diagnose and communicate to your center.
And Eternal Hospital is the only hospital in the state of Rajasthan who's having 24/7 in-house cardiologists. Cardiologist sleeps in the hospital. So there is no delay in the diagnosis. There is no delay in the transfer to cath lab. Even in the 12 in the night or 2 and 2 in the morning, patient is being straight away taken to cath lab and get the primary PCI done.
See, I understand. Medicine is also our livelihood. It's a business. Where it comes to saving a patient's life, where every minute counts, I think people are playing games doing this. You have to realize, just imagine what would happen. Exactly like what you mentioned, Atul, that a patient would end up in a place. Now, it is only advertised they have PCI, but there is nobody available at 72% of the patients I have done in my career, and I have done more primary PCI than anybody else on the planet, and nobody can catch up because that's all I do. 72% of my patients are between 1 and 5 in the morning. You really believe in India it is different? That's what it is. So you need a center like what Dr. Sharma just mentioned, Sanjeev Sharma mentioned, that to provide a 24/7 facility is not easy, it is not inexpensive, and the logistics are very challenging, which does not happen at these small places. You'll go there, you'll get streptokinase. Next morning when the doctor has time, they'll do the angioplasty, and you come out thinking, you know, the ejection fraction is almost exactly the patient you showed, 25%. The poor guy is going to be looking at a transplant. For the rest of his life, he'll be popping medications and requiring devices.
So now we can move forward as we are running late. Yeah. Any comments from the physician community?
Congratulating team for creating such facilities in Eternal Hospital. It will cater a small, very small population of Rajasthan, and lot more to be done. Still we are struggling to convince patient what are the symptoms of heart disease. In remote areas of Rajasthan, people don't know even symptoms. Even if they present to physician say, you have to be admitted. He say, मेरे तो घर पे शादी है, मेरे तो मेहमान आने वाले हैं. The seriousness of heart attack is still not reached to the public. So what is more required is an education program by the government or by any agency to tell the people how heart attack present and what to do when heart attack occurs. Because that is the primary point. Most of the delays which I have seen in my life is at the level of patient or relatives when they decide to take patient to the hospital. That is most important. When patient himself realizes that he has developed a heart attack, and when the surrounding people, health provider realize that it is what is seriousness and where to reach. So there are many things to be done. In Jaipur, you are doing it is good,
Realize that
but
it is
lot
what
more
is seriousness and where
centers
to reach.
has to be developed,
So there are
and
many things
may
to
not
be
be
done.
so efficient. But a person from Pali or Ganganagar cannot come to Jaipur. We have to have different satellite programs in the Rajasthan, in the whole India, if we want to be successful. Thank you.
About the education part, at the Eternal we are doing regularly webinar for the public as well as for the doctors also, and it's a regular feature for educating, because the most important thing is the education of normal person, for people to know when to go, and it's very important about the that golden hour of the heart attack. So we are doing regularly. It's our basic of this Rahat program, that educating people and as well as physicians the importance of this Rahat program.
I am working in government setup 80 kilometers away from Jaipur. You said whether we should give STK or not. Patient is most of the time जा भी सकते हैं, रुक भी सकते हैं. This is the attitude of patient. What should we do? Coming within 2 or 3 hours, what is line of treatment?
Look, one of the things I always tell people that don't ever assume that I'm not familiar with India. I mean, even living all the years, my right side of the brain is still, I completely understand. I have been on several meetings where I have said the hardest place to treat a patient with MI is in India. I understand everything you're telling me. Yet, the country is also changing. I mean, they are providing insurances in a ways which was never possible before. I think the previous gentleman who asked the question, that really is the essence of what we need. Unless there is going to be a sustained public campaign, you're not going to end. Even the solution to what you're saying is public campaigning, and it's only a matter of time. I have always known that all these things are going to happen by themselves. Lumen Global is only a catalyst. I come here, I make patients aware, I stir your conscience, and things will start happening.
Yeah, share your experience with one of the patient who had a cardiac arrest and then rushed to our center within 2 hours and did undergo a diagnostic angiography as an emergency procedure. He had a bad severe disease, was taken off surgery very next day, and he survived. He had a cardiac arrest. He gave
I just rang him. I rang Sanjeev, and he was ready at 5 o'clock in the morning, and patient was survived. He had cardiac arrest. We gave DC 3 times. In spite of that, he's still alive. It is only the efforts of Dr. Sanjeev. Thank you.
Sir, one thing I want to share that one of my colleague faced a problem. Patient came, Dr. साहब मैं तो आया था यहाँ इसलिए मैंने सोचा आपको दिखाई लूँ. Actually, he had some heaviness in the chest, and he developed cardiac attack that time. That was proved on the ECG. So उसको कहा you will need to get the admission in the hospital, and you will get the proper treatment. मतलब he revengefully he told that Dr. साहब मैं ही मिला क्या आपको ये करने के लिए, and immediately he went out and he suffered the cardiac arrest at the doorstep, and he died. So this is the state of the affairs, you see, and definitely Dr. Samir Mehta told about the telemedicine. It is a very nice thing, but you see, telemedicine is how to set up it, and what cost will it have for us, how much cost it will occur for us. So that has to be narrated in detail.
ये अगर आप देखें ना, ये बहुत आसान सिस्टम है. There's nothing difficult in it. Telemedicine actually is such a cost-effective methodology. It can be at the lowest possible cost. The benefit of it is that, see, you have to realize, the purpose of Rahat is to make heart attack, exactly what I showed you, an umbrella of AMI coverage for 100 million people. That is what telemedicine does. It just helps you bring the patient to the centers which treat it. Now, nobody says there has to be only this number of spokes or hubs. That can all be expanded like exactly how we did. So all of that is possible. And again, my last request, we have to move to the next session, is you have to spread this awareness. This thing should be a regular discussion, not only at this conclave. People should be talking about this all the time.
Thank you.
Move to the next session.
Thank you so much. And now, as the short of time, I just want to let you know that we are combining two sessions, session 4 and 5. So I would like to invite our chairpersons on stage. First of all, Dr. Subhash Kala, Dr. V.V. Agarwal, Dr. G.L. Sharma, Dr. Prem Ratan, Dr. Samin Sharma, he's already there, Dr. R.K. Madhok, and Dr. S.M. Sharma. Dr. Sanjeev Sadana and Dr. Saurav Kalia. I would request you to please be on stage. Sorry, Dr. Saurav Jaiswal. I would request all of you to...
Of revascularization in stable CAD. So Dr. Sharma is going to enlighten us what's the result of latest ORBITA trial and how does it guide in our clinical practice.
Okay, so after this lively discussion, and as repeatedly mentioned, the Rahat program is not the ESCC, it's not the hospital program, it is the public program, and which we really want to put life into it to make it better, so save the life. Anyway, next 18-20 minutes, now I'm going to take you through this very controversial trial called ORBITA, which came last year, and take you through what we do for coronary revascularization in stable CAD. We are not talking about what we just talked in the STEMI patients. That's the STEMI patients, everybody get PCI. There's the stable coronary artery disease. So there the questions are different. While the time is a sense in the STEMI patients, the difference here is that patient may have disease you found out by CAT scan, CT angio, stress test. So questions are different. Patient have angina, ischemia. People say, well, your stress test is positive, but just many patients will deny. Say, but I feel fine. I walk 5 miles. The studies have shown whether you have chest pain or not, but if you have ischemia on your stress test, it is as bad, rather even worse than having angina. Then, of course, you need to know where the blockage is, and then complexity. So, which case should get stent, PCI, which case should get the bypass surgery, or which case should just get the medical therapy. So, that is what we do for the PCI and stable syndrome is to reduce angina or ischemia and to improve exercise tolerance. We are not saving lives. That's not the goal. That's not in any trial of the stable angina showed. It just showed to improve the overall well-being of the patient, exercise tolerance, and decrease angina. So this will be the two important topics. Most important is the first one, appropriateness of PCI, which versus medical therapy, and secondly, which case you should go send patient for bypass surgery or PCI. So this is, I'll give you an example, 61-year-old patient. This is a few years ago. Patient was on, had a positive stress test for angina, class 1 symptoms, apical ischemia, good ejection fraction, came for cardiac catheterization. So see the blockage, which actually I'm going to show in this view. This is one of the branch of the circumflex has 80-90% blockage, LPL. Other arteries are fine. The main artery is LAD, which is good. And then, of course, right coronary is fine and good heart function. Question is what to do. What we do when we find the blockage. Majority of them put on medical therapy. But then some of the patients break through the medicine and then undergo PCI or cabbage. Whether 7-8% of them go PCI, 2 or 3% goes for cabbage, but majority of the patients are treated by medical therapy of aspirin, beta blocker, nitrates, calcium, here necrondin, nicorandin, ranolazine, statins, and of course the various blood pressure medications and ACE and ARBs. Routine treatment for these patients with coronary artery disease. Now, should you do PCI in these cases? So we have many trials. In the past, 5 of them are here, and basically showed that the PCI, there's no difference in mortality and MI, which I mentioned right in the beginning. It basically gives more angina relief. So basically guideline was that PCI reduces angina and of course improves the exercise tolerance. Now then there was a major trial which was real disturbing in the sense that never the concept was that PCI reduces death or MI. But the trial endpoint, Courage trial, was reducing death or MI at 5 years and basically found no difference. No surprise. But what it did, it really changed the interventional practice. So even ischemic patients, by the physicians being relied that now you don't have to send the patient for catheterization. Volume of the intervention went down by 25% in United States after this trial. But what did show that if you don't do the PCI at time 0, 1/3 will require PCI in usually 9 months to 12 months, but at least not at the cost of having death, MI, or stroke. Also, we found in the same trial that if you have ischemia, so they did a stress test in the beginning, then they did a stress test about 18 months later. So if patients who continue to have ischemia, ischemic burden, so clearly that those patients, the PCI obliterated that ischemia compared to medical therapy. So if you have positive stress test, even if the Courage trial showed no benefit, but if you positive stress test, PCI did a better job than medical therapy. Why? Because once you reduce the ischemia, you live longer compared to if you did not. So basically that was the message from the Courage trial, but what we learned is that medical therapy is very good. So why that is a difference, which we had just talked about in acute coronary syndrome. Acute coronary syndrome occurs because of the thrombus formation, plaque rupture, sudden development obstruction of the lumen, which cause MI and death. What happened in the stable CAD? It's a chronic process. There is a gradual blockage of the artery, which causes supply and demand mismatch. You do basically, it cannot open, cannot dilate when somebody exercise, walks, and so forth. So there is more of a ischemia angina compared to plaque rupture or death. What we do in acute MI is basically do the PCI. What we do in stable syndrome, do the PCI, medical therapy. If medical therapy fails, then only we do the PCI. That is what we learned. So what we did, that the major Courage trial made our society come up with the guidelines that which patient should get PCI. So these are the called appropriate use criteria, OC, for coronary revascularization. Initial was 2009. And then updated came in 2012, and basically they took into all the aspects of our coronary artery disease patient in account, what symptoms patient was, asymptomatic or angina class 1 to 4, non-invasive risk assessment, assigning them low, intermediate, or high risk, or patient was on anti-ischemic therapy, 2 or more drugs, and based on the coronary anatomy finding. And these are basically angina class, risk assessment, and basically what they did is, came up with a very nice, simple color grid. You put all of them into equation, medical therapy, ischemia, coronary artery disease, and if you have an I, means inappropriate. So those patients should be treated by medicine, should not have PCI. The green is appropriate, should get PCI. And one of the thing is proximal LED. You see the proximal LED, even without any medical therapy or stress test, they put it into A or U, asymptomatic patient. This is what we call widowmaker. Clearly, that those are the patients should get PCI irrespective of any testing. So they give importance to this. So I means do not do PCI. Second, once you get a little more positive, more intermediate risk group patient, class 1 or 2 angina, clearly you see inappropriateness decreases in these cases. Once you go to a higher class 3 or 4 angina, or multiple stress, high risk stress test, most of the PCI was appropriate except if you are doing in the CTO. So our case, let's go back to this. This patient has a one vessel disease, has a class basically where will it fit? Patient has a one vessel disease, not a proximal LAD, was not on medical therapy and low risk. Ideally, you will do the stent in that case. But by the guideline, you say no PCI. You put this patient on medical therapy, and we know what was the outcome in the Courage trial, that about 1/3 of them, of course, many of the people, this was back done. See that 2010. The guideline came in December 2009. We are already we applied then. And of course, a lot of people were upset. How can you leave a 90% lesion? But we knew it was safe. And then also learned that these patients, some of them, about 1/3 to 30 to 40% of cases, will continue to have angina, will break through the medical therapy, and they will come back for PCI. And this patient, about 4 months later, developed some more symptoms, came back, simple, we did a stent as an outpatient, did extremely well, and went home on aspirin, prasugrel, and of course CAD risk factor modification, and continue maximum medical therapy. So just to say that at present, there is appropriateness use criteria. Any PCI we do is being evaluated in United States based on the OC criteria, whether it's appropriate or not, and that led to understanding that what was the inappropriate. So basically it turns out to be, this is the data of the ACC and CDR, back then, that in stable patient, about 12% of patients, if we would have done PCI on that case, would have been in this category of inappropriate, about 12%. So now at Sinai, back then, the 2012 data, if you see for the New York State, 13.4, and we were 3.7. So clearly you will have some inappropriate cases because the scenario does not fit what has been recommended. But overall number, anything less than 5% is a part of quality matrix for ACC and CDR. And this is, since then, what has happened, inappropriate number has gone down significantly in various countries and so. So then we also added that just don't go by the angiographic finding, additional testings. By look at the blockage, by intravascular ultrasound, OCT, which is more sophisticated, near to looking at the fat. Actually, this machine has been discontinued now. Or then come up with a new test called FFR. And that is by giving IV adenosine, and you see the gradient across the blockage. So one is looking inside, how bad is the lumen of the artery is, and if it is less than 4 millimeters square, that will give the trouble. For the left main, less than 6 millimeter, showed that even if on angiogram, look 50-60%, use IVUS to predict whether that lesion will give trouble. More important was the FFR. And FFR was giving IV adenosine, which is a routine. Every hospital has it, should have it, and that's a very, I would say, quality parameter. You look at the gradient across the blockage after IV adenosine, and the trials have shown that if you're less than 0.8, PCI is appropriate. You may have 80-90% lesion, but your FFR more than 0.8, patient do very well. So that is, multiple studies have shown that, and that has become the part of our routine practice at this time, because FFR-guided PCI is superior to angiographic-guided PCI. So unless having MI, it's not for the MI patient, it's for a stable patient, because overall, the angiographic-guided PCI gives you some idea, but FFR is very precise and causes, overall improves outcome and decrease the cost. Then question came, what if we give a more medical therapy to these patients who have FFR of less than 0.8? So this is a 0.8 medical therapy versus PCI in these patients, and turns out to be that if your FFR is less than 0.8, and if you give medical therapy, you have very high subsequent revascularization, urgent as well as total revascularization. So turns out to be medical therapy is not going to work if your FFR is less than 0.8. So clearly you should do the PCI on those patients, and this actually has shown that become the gold standard FFR-guided PCI in a questionable case, if not 90% or 99% lesion, not acute MI, stable patient, 50 to 70, 80% blockage, PCI should be decided based on the FFR. The latest, another test called instantaneous wave-free ratio, just coming to India at present, which is some studies have done to compare IFR with the FFR, so avoid the need for the giving adenosine. 2 trials have been done, DEFINE, FLAIR, and IFR, both showing the good correlation of IFR and FFR-guided PCI. Maybe IFR in next few years will replace FFR, but these are the physiological testing help you to identify which lesion should get the PCI. So what we learned from various trials, that PCI decrease angina, improve exercise tolerance, decrease ischemia on stress test, better quality of life parameter, reduce urgent revascularization in FFR of less than 0.8, and properly done may even reduce the overall outcome. So this are the hard fact. Anytime we have a fact, we have a challenge. So challenge was the trial. ORBITA trial, the PCI, which is the double-blind randomized control trial, basically took the patients as if they are going to have a PCI. They punctured the groin. Catheters were advanced. In half of them, PCI was not done. Sham PCI. Patient did not know whether had a PCI or not. The goal was whether PCI increased exercise time more than placebo. And that was the primary endpoint, and of course, the reduces angina. The fact which has been already established, and basically a very intense trial done from Europe, England, and 200 patients were randomized. They really took the patients, did a multiple studies beforehand, made them the maximum medical therapy, then they have a stress test, and then trained them, and after the stress test, then they had an angiogram, and then went through the 6 weeks, the blinded follow-up, followed by the stress test and rest of it. So basically, very blinded, sham control trial, and what it did show that, of course, these were the very significant lesion, many of them, but many of them were not significant because about 1/3 of them have FFR of more than 0.8, so which you'll say should not have a PCI, but even in PCI group, those people have a PCI, and the primary endpoint was the PCI did increase the exercise time after 6 weeks of the therapy from 28 to 28.4, in the placebo group 11.8. So difference was only 17 seconds, did not make a p-value. And therefore, the big news last year in October after TCT and various news media that PCI doesn't work. The bare concept that PCI improved exercise duration and did not work out. Only thing did work out is the stress test. That PCI did improve the overall, the positive in terms of the stress. They did a stress echo. So stress echo point of view, those parameters were better. As far as angina time, also not different between the PCI or placebo group. And this is a Seattle Angina Questionnaire. No difference. And very only difference came is the PCI did improve the wall motion index, that is the stress test. So what did it basically did? That trial was the first of its kind and really made a big news showing that PCI does not work. Heart stent failed to ease chest pain, multiple news. So PCI, we thought, we already survived the Courage trial blow. Now there is another big one from the trial which was done. ORBITA, a very small trial, but got a very bad name for the PCI. The PCI does not work. But it was only 6 weeks trial. Nothing was done after that. So clearly multiple news and so forth, and a lot of editorial was bad also, that PCI probably should not be done even in a stable angina patient. The trial has its own endpoint. Very selected patients were enrolled in the trial with a one vessel disease, and so whatever it is, we clearly knew that this is not the right way. It was too much high for too little gain, and unlike to change practice, because guess what happened? After a few months, patients who were in the sham study, control group, 85% had the PCI anyway. So we'll never know. The PCI will work after 6 weeks or no. So we don't do any procedure for 6 weeks. So therefore, the ORBITA trial basically did not decrease or change our thinking about the coronary artery disease stable angina patient. So it was, but eye-opener. Eye-opener basically, we always have to learn, understand what we do and why we do. Same time, the FAME trial, based on the, which I showed you earlier, 3-year data came that the PCI-guided PCI, the FFR-guided PCI was superior to the medical therapy alone and so. So then question comes, which patient should get PCI or CABG? We have multiple trials, all have advantage, PCI and CABG. PCI is a very easy procedure, quick recovery, CABG, long-lasting, but initial morbidity and mortality, and then of course seen by the based on the angiographic criteria. We call syntax score. All the lesions, you can give it a number. They come up with a syntax score of low, intermediate, or high. And the guidelines have come that if you have a high syntax score, CABG do better than PCI. And even for the left main, if your PCI, the syntax score was less than 32, both CABG and PCI were identical. So what I had done is, again, we follow all patients at Sinai, and these are the 5 category of patients of stable CAD should be referred based on the studies of the syntax and freedom for coronary artery bypass. One is 3-vessel disease with a high syntax score of 32 and above. 3-vessel disease and proximal LAD involvement and syntax score of more than 22. 3-vessel disease in diabetics. 2-vessel disease in diabetic with proximal and mid LAD involvement or unprotected left main with syntax score of more than 32. Those are the 5 group of patients where studies have shown that the CABG is superior to PCI even in this era of excellent PCI results. And that actually has led to the guidelines also that these cases should be discussed with the surgeon, and then you decide. Many times, even if you recommend the patient, and we follow those patients, as I said, it's a quality matrix in the cath lab, 60% of the patients will decline CABG, despite telling them that you're going to live longer. So why? Because their question is simple. Everybody just think about the short, that can I just do a quick recovery? But as long as you present the data to the patient and do the right thing is the approach. So clearly that if you take, as I mentioned, many of these groups, PCI and CABG are equivalent. Only thing is the complex case, these are the guidelines that PCI, CABG is superior. So just to sum up, how do we treat patient with stable angina? You do a stress test. If negative, medical therapy. Positive, come to the cath lab. Less than 50% lesion, medical therapy. More than 50%, you do FFR. FFR guided. If you are more than 90%, I think you go with PCI directly. If you have borderline lesion of 50, 80, 90%, basically you do a FFR guided revascularization. If you have complex disease, go for CABG. Many times patients who have re-stenosis fall into the category that you avoid the stress test, they have symptoms, you directly go for an angiogram. So how does the FFR gets into? That if FFR is more than 0.8, then you go for PCI. FFR is less than 0.8, defer the PCI, just give the medical therapy. And that has shown to be very superior. Once you do PCI, and of course using IVUS and OCT for complex vessel CAD optimization really helps. So just to give the numbers, that overall medical therapy is really winning. Winning in the sense that all these trials have made us better try the medical therapy, and this is the data in the New York State that both PCI numbers and CABG numbers are declining, while the patient's survival is improving from the CAD. Number of the CAD has not decreased, but the CAD survival is improving, but both revascularization of PCI and CABG is decreasing, and that is, in my opinion, is basically the winner of the medical therapy, that really working very hard and very well, and we all physicians are working very good to treat these patients, but at time when there is appropriate medical therapy will fail, and then patient has to come back for catheterization. There you make a decision based on the FFR, do the PCI, or based on the complexity, send the patient for CABG, and FFR negative, non-complex disease, do very well on medical therapy. And thank you very much.
I would like to invite Dr. Jitendra Makkar for a very important and very relevant topic, that is how do I choose my NOACs? Because nowadays nicomaline anticoagulants not being used very often for the AF, for the stroke prevention. After introduction of the NOACs, Pixaban, Rivaroxaban and dabigatran, most of the patients we are choosing to go for the NOACs because of their advantages. So Dr. Jitendra will be giving an overview and in which situation, which NOAC we should prefer. And Dr. Jitendra Makkar is there with us in Ratan Hospital as the Director of Cardiology, and he is an excellent seasoned speaker. Definitely he will give a crisp insight into how to choose NOAC in your practice.
afternoon to all of you. Once again, I welcome you all, and I thank you all for sitting here after lunch also. It's a very heavy time, and everybody is feeling sleepy. As Sanjeev said, this is a very important topic because we have been using oral anticoagulants in our practice, and now we have many more drugs which we can use. And to begin with, I would say that never feel that these NOACs are a cardiologist medicine. Yes, physicians can use. They are safe and they are effective, so they can be used. That's why in next few slides, I'll be explaining you that how we can choose and optimally use these drugs in our clinical practice. So what's wrong with the traditional anticoagulants? Traditional anticoagulants, oral anticoagulants, if we talk, are the warfarin and acetylene, which we have been using. So they have many limitations. Basically, one is that they have very narrow therapeutic window of adequate anticoagulation without bleeding. So, and highly variable dose response requiring monitoring by lab testing and interaction with food and drugs. There was never a suspicion on the efficacy of warfarin, that is not effective in preventing stroke. That's not the case. It is the use of this drug which is so difficult, so cumbersome that we have to every time monitor the INRs, and then there are a lot of food and drug interaction, and you never know which patient respond to which dose. A patient may be having an INR of 10 and may be bleeding at a dose of 1 milligram per day, and another patient is taking of same weight, same age, is taking 5 milligram without change in the INRs. So that much variability is actually which was the major limitation of these drugs. So now they are NOACs. NOACs, if we say novel anticoagulant, I won't say they are novel now because we have been using these drugs for a decade now. I remember in India, Pradaxa was launched in one of the conference here in Marriott only, which was National Conference for Indian Society of Electrocardiology in 2012. So 6 years in India also we have been using this. But still the term NOAC stands true because now we call them as non-vitamin K antagonist oral anticoagulants. So there are two types of them basically. One is the direct thrombin inhibitor, which is dabigatran, and others are direct factor 10 inhibitors, which are rivaroxaban, apixaban, and edoxaban. So these four are there in the clinical practice, but edoxaban has not been launched in India yet. So, but we have dabigatran, rivaroxaban, and apixaban in our clinical practice, which we'll try to compare a little bit and which case to which drug should be used. So now advantages of these NOACs are that they are rapid onset of action, so there is no need for bridging. What we had to do is a patient will come to us, we'll write acetylene, and for 5 days we'll write LMWH also, then he will come back with INR. If still not 2, then we'll continue the heparin or LMWH. That's not the case with this drug. You write and forget, and there's no need of bridging. Predictable anticoagulant effect, according to there are various factors like creatinine clearance, age, weight, etc. But more or less, the effect is predictable, so there's no need of lab testing here. Specific coagulation enzyme target, so there's low risk of off-target adverse effects, and low potential of food interaction, drug interactions, so there are very few drug precautions and dietary precautions with NOACs. So first drug to be approved by FDA was dabigatran, which is a pro-drug, and it has half-life of 14 to 17 hours. It can be taken once or twice. In trials, it was used as twice a day. So in clinical practice also, it is twice a day. And but there is some drug interaction with this drug. Verapamil, amiodarone, quinidine, dronidrone, and some antifungal agents cannot be given because they are PGP inhibitors. Basically, PGP is a glycoprotein which helps in efflux of toxic substances from the cell. If they are inhibited, then cell concentration would increase. So actually it's a serious interaction because verapamil and amiodarone, these are the true drugs which we are using very often for AF also. And we have to use these drugs for AF. So we have to be very careful that if we are using dabigatran, verapamil and amiodarone should be avoided as far as possible. Otherwise, there should be a strict monitoring of this. Another drug, second drug was rivaroxaban, which is again direct factor 10A inhibitor. It has bioavailability of 80%. Again, half-life is almost same for all of them, and there are lesser drug interactions with rivaroxaban. Apixaban, again, factor 10A inhibitors. This was the last drug to be approved by FDA. It has a little faster action, 1 to 4 hours, and it is predominantly metabolized in liver, and it has a mild PGP inhibitor action, so there's hardly any interaction with any drug. So if we compare them, mechanism is, we discussed already, dabigatran is a prodrug, and the problem is the bioavailability, but dose is according to that, so that is not a clinical problem. Rivaroxaban is more absorbed better with food, so whenever we are prescribing rivaroxaban, we should advise the patient to give with food, and bioavailability of other two are reasonable. Then important thing is renal excretion. Dabigatran has renal excretion 80%, so if patient has renal impairment, we have better drugs. We should not use dabigatran in renal impairment in less than 30 ml creatinine clearance. Then little bit side effects, dyspepsia with dabigatran, and intake with food is mandatory with rivaroxaban. Now what are the indications? Clearly there are 3 indications. First and foremost and most common is the prevention of stroke in patient with non-valvular AF. When we say non-valvular AF, there should be no significant valvular disease, more than moderate MS or severe MR or prosthetic heart valve. If that is not there, then we should use these drugs. That is non-valvular AF. So prevention of stroke in non-valvular AF with 1 or more risk factor, that means CHAD score of 1 or more. Second indication is prevention of venous thromboembolism in patient undergoing total hip or knee replacement. And third is prevention and treatment of venous thromboembolism. That is, there are the 3 indications. So there are few contraindications also, non-hypersensitivity of course, clinically significant bleeding, renal impairment less than 30 ml, though in trials up to 15 ml per minute creatinine clearance these drugs were used, but general recommendation is not to use these drugs if creatinine clearance is less than 30. Hepatic disease, recent high-risk bleeding lesion, pregnancy, breastfeeding, recent stroke, recent major surgery, GI bleed, recent fibrinolytic therapy, and concomitant warfarin therapy. These are in contraindications for NOACs. So what we do in patients of AF these days, if they come to us as paroxysmal AF, that doesn't matter whether it is paroxysmal AF or persistent AF or chronic AF. That's a separate subject, but AF for anticoagulation is AF, whether it is happening paroxysmally or persistently. So we just rule out valvular AF. It is if we think valvular AF, common sense, if valve disease is leading to atrial fibrillation, that's a valvular AF. And if valvular disease is bystander, not enough to cause AF, that can be considered as non-valvular AF. So if it is valvular AF, we have to use vitamin K antagonist. There are few studies going on in the rheumatic heart disease patient, but till any data is available, we should avoid using these drugs in rheumatic heart disease patients. If it is non-valvular AF, we have to look for the CHAD-SVASc score. That I'm not discussing in detail here, that's a separate subject. But if it is 0, or in case of female 1, there is no antithrombotic therapy required. But if CHAD-SVASc score is 1 or 2 or more than 2, then we have to look for the bleeding risk. And for bleeding risk also, we should use Hasblad score, which is easily available in the books and the internet also. So if we think that patient is not at a high risk of bleeding score and renal impairment is not there, renal impairment is there, we should use vitamin K antagonist, and if renal impairment is not there, we should go directly for the NOACs. So the message here is that it's not to be thought that if patient is not tolerating warfarin, or if patient is having labile INRs, or if patient cannot get CT test done regularly, then only NOAC should be used? No. They are efficacious, they are safe, so they can be used as first-line drug. The problem is not the safety or efficacy, problem is the cost. As with the patent goes away, these drugs will be more cheaper. But till then, the most limiting thing is the cost. Otherwise, all AF patient can be put straight away on the NOACs rather than vitamin K antagonist. So this is a good slide comparing the trial doses of all these 4 drugs. So very simple message here that if somebody asks me for stroke prevention, which is the most effective drug and dose, I would say dabigatran 150 milligram twice a day. Second to that would be apixaban and then rivaroxaban. So they are definitely superior to warfarin in prevention of ischemic stroke. They are superior to warfarin. Even that this 110 milligram of dabigatran dose is non-inferior, but that is not superior. So these all drugs, more or less, we can say that all drugs are very effective in preventing the stroke, and they are better than acetrom and warfarin. Now, what about safety? What about lack of major bleeds and other fatal hemorrhages? Then we can see here that the most, according to trials, according to comparison of these trials, though there is no head-to-head comparison, but according to the data of these trials, the apixaban, I would say, is the safest as far as bleeding is concerned. And 110 milligram of dabigatran is safe as far as bleeding is concerned. So if you want safety and efficacy both, and patient is at high risk of bleeding, you can use 110 milligram. Otherwise, this 150 is also safer than warfarin, but yes, because of some GI bleeds, the rivaroxaban was not safer than warfarin in these trials. So how to dose them? If patient's creatinine is normal, creatinine clearance, nowadays eGFR, the laboratory itself gives you the creatinine clearance. But if it is more than 50 ml, that means normal creatinine clearance, 150 milligram of dabigatran twice a day, rivaroxaban 20 milligram once a day, or apixaban 5 milligram twice a day. If it is 30 to 50 clearance, dabigatran 110, rivaroxaban 15, apixaban still can be used as 5 milligram twice a day. 15 to 30, at this stage, there is not recommended to use, but if patient's creatinine is more than 1.5 and is older than 80 and less than, then 2.5 milligram of Eliquis or apixaban twice a day can be used in this population where creatinine clearance is low and patient is low weight and advanced age. But general recommendation is that less than 30, we should avoid using these drugs. So 110 milligram twice a day can be used for people more than age of 75. Treatment of DVT-P, although 4 of them, they are all FDA approved for DVT also, but most commonly used drug and first approved was rivaroxaban. Should be used when creatinine clearance is more 30 or more than 30. And to begin with, 15 milligram twice a day for 3 weeks and then followed by 20 milligram once daily. The duration to be decided according to the case. So, choices of NOACs, when to use which. If patient is high risk of stroke, high CHA2DS2-VASc score, we need more stricter prevention, go for dabigatran 150 milligram BID. Or here, I would recommend rivaroxaban 20 also, because in Rocket AF trial, there were more population of high CHA2DS2-VASc score. That's why the results were not that appropriate, and high is the CHA2DS2-VASc score, high is the HAS-BLED score also. That's why maybe in that trial, bleeding was also a little higher. But I would recommend that these 2 drugs. And if there is previous stroke, rivaroxaban 20 milligram should be used. High risk of bleeding previously, either you use apixaban 5 milligram or dabigatran 110 milligram. If patient is having gastric intolerance, dabigatran cannot be used. And if there is GI bleeding history before, only apixaban can be used. Dabigatran 150 and rivaroxaban cannot be used. Compliance problem, patient is not able to take twice daily, he believes more in once daily dose, then we have to give rivaroxaban. And more than elderly with impaired renal function, we can use apixaban 2.5 milligram twice a day. So in he and knee replacement, also there are defined doses. Dabigatran can be used here as 220 milligram once daily, rivaroxaban 10 milligram once daily. And if creatinine clearance is 30 to 50, same dose, or apixaban 2.5, and less than 30 is contraindicated. So how to switch? If somebody is taking low molecular weight heparin and we want to switch to NOACs, what to do? When next dose of LMWH is due, like for example, twice a day low molecular weight heparin, morning it has been given, from the evening we can start with NOAC. For IV conventional heparin, immediately we can stop the heparin and start the NOAC. If patient is on warfarin, we have to stop the warfarin, wait for the INR to come less than 2, then we will start this. And if we want to switch from dabigatran to low molecular weight heparin, then no bolus is required, but start 12 hours after that. And for rivaroxaban and apixaban, start 24 hours after that, because the half-life is little longer, so start 24 hours that. And if from NOACs we are switching to warfarin, we have to continue NOAC because warfarin will take time. Then he has to come back with the INR. If it is more than 2, then we have to stop the NOAC. So renal function is an important component in dosing of NOACs. So I think we have discussed already these doses. So very important for many of us sitting here is the coronary artery disease, atrial fibrillation, and stroke. Now what to do? You cannot simultaneously prevent all three. Either stent thrombus will happen, or stroke will happen, or bleed will happen. So we have to make a balance to prevent all three, but it's really, really difficult to prevent all the three. Either we can take care of the stent or the stroke or the bleeding here. So we have to really counsel the patient that he has to get ready for all the consequences here. But a very simple thing, that if patient of acute coronary syndrome and he needs oral anticoagulant after acute coronary syndrome, if bleeding risk is low, triple therapy can be used up to 6 months. Then NOAC has to continue either with aspirin or clopidogrel after that. And after 12 months, only NOAC is fine. But in case of high bleeding risk, we can continue triple therapy still for 1 month. Then for rest of the 11th month, we can use dual therapy and then only NOAC. So similarly, in patients with OSC after elective PCI with stent and atrial fibrillation, again, the bleeding risk is low, triple therapy for 1 month, then 12 month, then up to next 11 month dual therapy, then oral monotherapy. And if patient is high bleeding risk, we can use only for 3 months, 6 months the dual therapy, and then we can continue the monotherapy. So initially triple therapy, then dual therapy, then only NOAC. That should how it should be. And quickly, what we can do when patients bleed. Now, fortunately, this dabigatran has the antidote, but the others are also in development. So soon we'll have antidote. So there will be less worries in our mind. But believe me, I have been using dabigatran first, and then rivaroxaban, apixaban, everything. But we haven't have any fatal hemorrhage till now with good doses. Just we have to take care of their creatinine clearance and the other drug interactions to some extent. So they are safe drugs, but even if some bleeding is there, if there is mild bleeding, like some mild gum bleeding or once or twice with the sputum or something, we can ignore. Or if that indication is not that strong, we can stop as well. But if it is moderate to severe bleeding, we have to take care of the cause of the bleeding. We have to give some plasma products, blood, whatever we do routinely for any bleeding. bleeding that we have to do. And in case of dabigatran, we have now the antidote also, so that can be administered. What do we do if patient is on NOAC and he goes for surgery? Very simple. If surgery is major, stop for 3 days. If surgery is minor, stop for 2 days. And if patient is having creatinine clearance is high, then for any surgery, stop for 3 days because drug clearance will take more time. So for major surgery, 3 days, for minor surgery, 2 days. And if patient has renal impairment, stop at least for 3 days, or if possible for 4 or 5 days, so that there is no risk of surgery-associated bleeding. So conclusion, well on time. New anticoagulants have shown to be a favorable balance between efficacy and safety with compared with vitamin K antagonists. Advantage of NOACs is again those avoiding the food interaction, drug interactions, rapid onset, rapid offset, everything. And further research is underway to develop reliable and accessible measure to monitor the anticoagulant effect of the new agent, as well as antidotes with the ability of effectively reverse anticoagulation effect. Thank you so much.
It was an excellent overview of new or non-vitamin K oral antagonists. And everyone has a clear idea when to use which NOAC. Renal impairment, significant dabigatran should be avoided, and better to prescribe rivaroxaban, apixaban. And for other issues, more or less they are same. High bleeding risk, apixaban is better. And now we move on to the next talk. We have clubbed session 4 and session 5 together. So we are going for the next talk is non-cardiac surgery in a cardiac patient, post-PCI, the role of physicians. So
okay, some of them which already have spoken, particularly with the anticoagulants, what to do with these patients. I'll start with the case. 89-year-old male, history of MI in the prior PCI, has some unstable angina, on hemodialysis. This is the electrocardiogram, inverted T waves, troponin was negative, high creatinine, hemoglobin, and the basically angiogram showed very complex disease, subtotal right coronary artery, calcific, and this is the LED. See the ghost of the vessel, very calcific, left anterior descending, and what the LV gram actually was fine in this particular case. Moderate, fine means just mild LV dysfunction. For the purpose of it, because of the LED very significant, we did a rotational atherectomy, followed by 2 Zions stent placed in this particular case, and the final results were like this. So, looks good. Patient did fine, and of course, we always calculate various bleeding and other risk. Patient was discharged because of age and stable CAD on clopidogrel 75 milligram, aspirin 81 milligram. Went home next day. Now, 10 weeks later, fell, slipped, X-ray shown, peritrochanteric hip fracture. Now you do what? Very complex PCI. We had just done barely 2 months ago. And now we have a hip fracture, patient needs surgery. And this is the trouble. So that is where the whole issue comes, of the non-cardiac surgery. And it is an interplay of various risks. Most important is, we call it a combined ischemic risk. That is the PCI to surgery interval. So when patient had a PCI in the natural history, and when you need the surgery, is the most important determinant how you are going to make a decision. Then, of course, comes with your depth cessation, which actually links to the interval. Then, clinical and angiographic characteristics, how complex the lesion was. Because we know, more complex lesion require longer antiplatelet therapy. Simpler lesion, you can stop antiplatelet therapy sooner. And then, of course, the interplay of the BMS versus DES. Although now we learn that BMS, many of the DES actually have a lower stent thrombosis than bare metal stent. So bare metal actually has almost disappeared. In our lab, in Mount Sinai, 98+% are done DES. Rare case of the BMS is because of the large vein graft, 5 millimeter and so use BMS. We also, here also, right, very little BMS being used at present because DES is a standard of treatment, and but interplay of these factors makes the combined ischemic risk, of which most important is the PCI to the surgery interval. What happens during surgery? Why are we that much worried about? One is the withdrawal of the protection, increased inflammatory state, and platelet activation. All these things are happening in these patients. So if you stop those, antiplatelet therapy will be trouble. Then surgery itself is a prothrombotic state. Inflammation, more thrombosis, more platelet activation, and your stent has not been endothelized. So now you stop your antiplatelet therapy, boom. You have a non-cardiac issue, having a hip fracture. Now on top of it, you have myocardial infarction because you have to stop this antiplatelet therapy. So this is overall, I mean, I'm sure similar number will be in India. About 20% of the population require non-surgical procedure. So we are about 220 million population in United States. Mortality of the non-cardiac surgery, majority based on what type of surgery it is, about 2 to 5%, and about 2 to 8% require have myocardial infarction. There are many guidelines over the years, and what I will allude, some of them is the 2014. One is the two types of MI occurs in this non-cardiac surgery. One of them is your typical MI, plaque rupture, thrombosis, which we call type 1 MI. Clearly, patient has a significant CAD, going for surgery will have MI. Because of, and should you take care of it or not take care of it is a separate issue. But that is the traditional myocardial infarction type 1. The second MI is, that is what occurs more commonly in these non-cardiac surgery called myocardial infarction type 2. And type 2 is basically oxygen supply demand imbalance, vasospasm of the coronary artery, some dissections, or some non-clear region which we don't even know. Maybe just a small thrombus made, disappeared but caused the MI. So these are the various factors which they very elaborately discussed in the recent guidelines of the definition of the MI, that multiple regions for the patients without even significant CAD, when they are, I'm not even talking about the stent patient, even without significant CAD, when they go for surgery, occurs oxygen supply and demand, and truly these are the secondary factors which cause myocardial infarction, and they behave exactly as the MI, natural MI, rise in troponin and CKMB and fall, and associated with bad prognosis, just like troponin prognosis in patient with STEMI and non-STEMI patient. So behave similar way, and rather in some cases in a more malignant way, but yet many of them don't even have a coronary artery disease. These are the various factors just elaborated in the earlier slide causing the perioperative infarction. So as I mentioned, that they behave exactly like the myocardial infarction, have a higher mortality, whether it's a true MI or the myocardial injury, which is by the troponin, have a bad prognosis of 3 to 4 times mortality in these patients. So then we are called in, right? You have a patient, the case which was shown, seen by an internist or cardiologist. Now you say, well, what do we do? Or orthopedic now called the patient for clearance. So question is, when they call the physician for clearance, our goal is not to just say, okay, you can do it. You can do the surgery. Nothing will happen. No, we just risk assess. We optimize the medical therapy. We assess risk for cardiac complications and suggest interventions to reduce risk. Order test only when the results may alter the treatment. So in a case where you know that angiography is not going to make a difference, and so you don't need to do an angiogram. You don't do a stress test if not going to make a difference. And so basically, clinical judgment, we just give, it's a patient will be a low risk, high risk, or intermediate risk, or subsequent event. So now, there are the 5 decision component come. Is there a need for emergency surgery? Are there active cardiac conditions which will, does the planned surgery have a low cardiac risk? Does the patient have good functional status? And does the patient have clinical risk factor for a higher event? The clinical surgery emergency. Patient has an active GI bleed, exsanguinating. You had a stent recently. What you do? Go ahead. No, nothing needed. No time to stop any DAPT. Medication management, and patient have acute coronary syndrome. If not a stent patient, you monitor them, PA catheter, maybe a echocardiogram, hemodynamic support devices, and of course you follow these patients very actively in the ICU, CCU and telemetry setting. Go ahead and do the surgery and use the replacement product as needed because of the emergency surgery like aortic rupture, exsanguinating GI issue. There are active cardiac conditions. Which conditions we should worry about? Patient with unstable coronary syndrome, decompensated heart failure, arrhythmias, severe valvular disease, patients severe aortic stenosis. So that case will be high risk for non-cardiac surgery. What we do in those cases, patients having active chest pain and ST segment depression, those patients will go for cath. One will go for patient with a severe aortic stenosis or mitral stenosis, you do a balloon valvuloplasty to open the valve before they can be cleared for non-cardiac surgery. Then the question always comes, is it a low risk for cardiac event, that type of surgery? And they actually have defined that which surgery have high risk, intermediate risk or low risk. So any vascular surgery, aortic, major vascular and peripheral vascular surgery is considered in the high risk. Intermediate are intraperitoneal and intrathoracic surgery, carotid endarterectomy, head and neck, orthopedic and prostate comes in your intermediate risk. Low risk surgery, event rate less than 1%, are endoscopic surgery, superficial procedure, breast surgery, cataract surgery, low risk. So what will be less aggressive in the lower group. We have to be very aggressive in the higher group. And intermediate, you make a decision to risk stratify these patients based on what type of surgery patient need. The question always comes, if you want to assess the patient, you have to understand the patient functional status. How many times patient with a peripheral vascular disease, they go for surgery and say, no cardiac symptoms. Why? They don't walk. So they don't walk, you can't elaborate any of their symptoms and so. So this goes down to that the activity. So clearly have shown that more active the patient, better it is from the surgical point of view. And we see usually the MET in terms of the various activities, what patients do, and based on that, evaluate the risk that basically the patients with the good functional capacity based on the clinical risk factor, recommendation is that if you're functional and you have no symptoms, that's okay, you don't need to do any non-invasive testing. But if you're not functional, you need to assess. Those cases need to do a non-invasive stress testing, pharmacological, many of them, or stress test some kind. Then lastly, the patient have clinical risk factor for higher event, which we have shown. Ischemic heart disease, heart failure, CVA, diabetes, renal insufficiency, and high risk for surgery. All these patients require extra perioperative management to improve their risk because clearly all these are dependent on the type of surgery, functional capacity, and clinical characteristics of the patient. Now, with the DES, what is the issue? Issue is risk of stent thrombosis, risk of periprocedural bleeding, and of course, you want to delay the surgery, then issue about the non-cardiac. Many times the hip surgery had to be done within 5 to 7 days, because if you delay it, there will be aseptic necrosis and then the big trouble happens for the surgical point of view. Now, there is one data actually came with Roxana Maran, the PI of the trial called Paris. What we have learned is that not uncommon, these stent patients, almost the 70%, you see, the require over the follow-up period some kind of a surgery, and based on the guidelines or based on the overall assessment of the patient and taken incorporation various guidelines, if you selectively interrupt the antiplatelet therapy for the short time, you still have a reasonable outcome. So what are the guidelines basically? That elective, for the DEPT, elective non-cardiac surgery should be delayed 30 days after BMS and after DES 3 months. And elective non-cardiac surgery should not be performed within 30 days or 3 months if it is elective. The second, the recommendation basically is the same way that whether the patient has a stent or not, that 1 month to 3 months is a very crucial period. So now what we learn is that no longer you have to wait for 1 year. And that is the key. In the past, DES means you have to wait 1 year for a non-cardiac surgery. Most of the guidelines have shown now that 3 months is good enough. 3 months good enough, so delay the surgery, semi-elective or elective surgery for 3 months on these patients. Now, many of them, if you need to do urgently, what can you do? We actually have 2 drugs. One is the Cangrelor and second is the small molecule of the tyrofibon or eptofibatide, that patient need urgent surgery. You have put a stent in the left vein, but now you can't stop the clopidogrel or other P2Y12 inhibitor. You can bridge them by either IV cangrelor, which is not available, which is, as I mentioned, short-acting, but very effective agent. But you can use a small molecule of tyrofibon eptofibatide based on the recent guideline. You stop 4 hours before. After the surgery, then you can resume your clopidogrel once patient start the oral intake. So clearly that you need to stop in a particularly bridge in high-risk patient if surgery need to be done within 3 months of the DES. So how discontinuation, as warfarin, you stop 3 to 5 days pre-surgery based on the bleeding risk. And NOACs, if the low risk for bleeding, you stop for 24 hours. If the intermediate risk for bleeding, 24 to 48 hours. High risk for bleeding or renal dysfunction, NOACs should be stopped for about 48 to 72 hours. So what also we learned, that few things we used to do, beta blockers, many trials have shown not beneficial. No need for prophylactic IV nitroglycerin. Statins, some data are there. Statins prevent myocardial injury in a non-cardiac surgery. Plus minus, some people give it, some don't. It has not made to the guideline that statins have to be done. While PCI is guidelines that you have to give high-dose statin before you elect to PCI, but not for the non-cardiac surgery. Then aspirin, and we have spoken about the beta blocker, no issue. And of course, there is some question whether should hold ACE inhibitors or ARBs and so. So the one point I really wanted to make from this Paris registry, which was Roxana Maran, the PI, published in Lancet 2 years ago, that if you take your patients who had a stent and you have no interruption, event occurs in 10.5% of cases. Then if you have disruption, 14.4%. And if you discontinue, very high. What does that all mean? It basically means that we as a physician, when follow the patient, stratify for the surgery, and you stop the drug for 7 to 10 days, event rate is not more than when you continue the drug. So very, very important message. The physician has a main role for this. Once you discontinue, patient discontinue, physician discontinue because of ignorance or so, that's where the trouble occurs in these patients. So back to our patient. This patient was admitted. Clopidogrel was interrupted for 5 days. Operation of fracture was performed on aspirin monotherapy. 2 days post-op, when patient was PO intake, clopidogrel was restarted and patient was discharged to geriatric rehabilitation clinic and doing well. So key is the incorporation, interrupting antiplatelet therapy, even this high-risk case who had a very complex LED disease and had 2 stents and within 2.5 months. But follow under physician instruction, interrupting the antiplatelet therapy for a short time. You don't want to do it. You want to wait at least 3 months. But if you cannot wait it, so in waiting for a short time, interrupting for a short time is completely safe. Really very high-risk patient, the best way would be that you stop your antiplatelet therapy. On day 3, you start IV tyrofibon or eptofibatide. Heparin alone will not be protective. Then do the surgery 4 hours before you stop the drug. And post-op, start the oral antiplatelet therapy when patient taking the drugs. Thank you very much.
Now we can move on to the next topic by Dr. Ravindra Rao. This is about what physicians need to know about the current valvular heart disease guidelines. And also he'll be clubbing it to the next talk, that is a tower moving from high risk to intermediate risk. So Dr. Ravindra Rao is a director of tower and structural heart program in our hospital. And in structural heart intervention in tower, our hospital is leading not only in Rajasthan, but in northern India and in the country too. So over to Dr. Ravindra Rao for his overview about the valvular disease guidelines and the tower.
Good evening, everyone. Thank you, Dr. Sanjeev, for those kind words. And I can totally understand that we are running 1 hour behind the schedule. I'll try to be very precise and try to finish it on time. That's there. Thank you so much. So valvular heart disease, what is new? As you know, the most common cause of valvular heart disease in India is still rheumatic heart disease. So this is based on the 2017 Focus Update on Valvular Heart Disease, which was published or released by the American Heart Association. The new thing which has come out in the valvular heart disease is the classification and the staging. So there is stage A, B, C, and D. A is patients who are at risk for valvular heart disease. B is progressive valvular heart disease. C is asymptomatic severe, and D is symptomatic severe heart disease. So in a clinical practice, mostly we encounter patients who are B, C, and D, and not really A. What is the role of echo? Echo is required to confirm the diagnosis of valvular heart disease, and transthoracic echo is recommended in patients with known valvular heart disease when there is a change in symptoms. You don't do routine echoes on these patients every 3 months, 6 months. No. It is only indicated if a patient already has a diagnosis of valvular heart disease, now there is a change in symptoms. Periodic monitoring with transthoracic echo is recommended in asymptomatic patients with known valvular heart disease at intervals depending on the valvular lesions. Cardiac cath, it is not recommended for all patients, but if there is a discordance between the symptoms and the echo finding, then you do a cardiac cath. Exercise testing, again very important. Our patients, they have a habit of concealing the symptoms. Almost everybody is asymptomatic until you start digging in and asking them the questions. So exercise testing is required in asymptomatic severe valvular heart disease to confirm the absence of symptoms and to assess the hemodynamic response to exercise. One of the most important example is mitral regurgitation. Mitral regurgitation is dependent on the afterload, and it changes with the change in afterload. So sometimes we do an exercise stress echo to diagnose the severity of MR. Patient has shortness of breath, and the 2D echo shows mild MR. They don't match with each other. So do an echo, reassess the mitral regurgitation. So we're going to go, this is an important slide. How frequently should we do echo in patients with asymptomatic valvular heart disease? Aortic stenosis, mild aortic stenosis, once in every 3 to 5 years. Moderate aortic stenosis, every 1 to 2 years. Similarly for AR, mild AR, 3 to 5 years, moderate AR, 1 to 2 years. Mitral stenosis, if the valve area is more than 1.5 centimeters square, 3 to 5 years. We did not do these echoes every 6 months, every 1 year. So for all mild disease, it's 3 to 5 years, and for moderate disease, it is 1 to 2 years. Let us see for severe aortic stenosis every year, severe aortic regurgitation every year, mitral stenosis 1 to 2 years, and for mitral regurgitation, it is very important. You do it every 6 months, because in mitral regurgitation, the indication to treat or intervention will change if the LV dimensions and ejection fraction falls, because a severe MR, EF less than 30%, MVR will not help. I'm not going to go into those details, but yes, this is again a very important update, which is of our clinical relevance. Infective endocarditis prophylaxis. So prophylaxis against infective endocarditis is reasonable before dental procedures that involve manipulation of gingival tissue, manipulation of periapical region of teeth, or perforation of the oral mucosa in following patients: prosthetic cardiac valve, including a TAVR, previous infective endocarditis, unrepaired cyanotic congenital heart disease, cardiac transplant with valvular pathology. And prophylaxis against infective endocarditis is not recommended in patients with valvular heart disease at risk for infective endocarditis for non-dental procedures. So don't give antibiotics for TE, esophagoscopy, colonoscopy, or cystoscopy in absence of active infection. These are again the new changes. Anticoagulation with vitamin K antagonist is indicated for patients with rheumatic mitral stenosis and atrial fibrillation. Anticoagulation is indicated with AF and CHAS2 VAS score of 2 or greater with native aortic valve, tricuspid valve, or mitral valve disease. Now, you already heard a talk on NOACs. Can you use NOACs in valvular heart disease? It is reasonable to use a NOAC as an alternative to vitamin K in patients with AF and non-mitral disease. So if patient has mitral stenosis, you cannot use it. But patient does not have a stenotic mitral disease, you can still think of using a direct oral anticoagulation. It's a class 2 indication. And it is required that STS score should be calculated for all valvular heart disease patients. Based on the STS score, if it is less than 4, patient is low risk for surgery, 4 to 8 is intermediate, and more than 8 is patient high risk for an open heart surgery. This is again, we're going to go over aortic stenosis. Stage A, B, C is asymptomatic severe aortic stenosis, and stage D, symptomatic severe aortic stenosis. So, because I'm going to go over stage D because this is the patient profile which we see in the clinical practice. And if patient has symptomatic severe high gradient aortic stenosis, is diagnosed based on the echo. These are the certain echo parameters. And the symptoms of aortic stenosis, as you are aware of, is dyspnea on exertion, angina on exertion, or exertional syncope. These are echo details, but this is the classification of severe aortic stenosis. The transthoracic echo is indicated in patients with signs or symptoms of AS or bicuspid aortic valve for accurate diagnosis of AS, hemodynamic severity, LV size, systolic function, and for determining the prognosis. Sometimes these patients have low EF and have low gradients, and diagnosis of aortic stenosis is difficult. So low-dose dovitamin stress echo is indicated to differentiate between a true aortic stenosis or a pseudo-aortic stenosis where the valve is not opening because the ventricle is not able to pump the blood. Exercise testing in aortic stenosis. Let us look at the class 3 indication. Exercise testing should not be performed in symptomatic patients with aortic stenosis when the velocity is more than 4 meters per second or mean gradient of more than 40. This is again important. There were some trials and some data earlier that people were using statins to prevent the progression of aortic stenosis. So statin therapy is not indicated for prevention of hemodynamic progression of AS in patients with mild to moderate calcific aortic valve disease. It's class 3 indication. Surgical AVR is the gold standard of care in patients with aortic stenosis, but interesting, the TAVR finds its name in the guidelines now. So TAVR is indicated for patients who are high risk for an open heart surgery. For an intermediate risk patient, it is a heart team decision as well as the patient's decision who is part of this heart team whether to choose between TAVR or surgical AVR. This is again the important slide. Patient is low risk for surgery, undergoes a surgical AVR, and intermediate risk surgical AVR or TAVR. Class 2A indication is the practicing indication which can be practiced. High risk, again, surgical AVR or TAVR. Prohibitive surgical risk, again, it is TAVR. So you see in this guidelines, already the TAVR has started coming down. Mitral stenosis, again, one of the most common valvular pathology which we encounter in the clinical practice. What is new? The definition has changed. Now, if the mitral valve area is less than 1.5 centimeters square, it is called as severe mitral stenosis. Earlier, less than 1 was called as severe mitral stenosis. Anticoagulation. Anticoagulation is indicated in patients with mitral stenosis and AF, MS and prior embolic stroke, MS and left atrial thrombus. Heart rate control agent should be used in patients with mitral stenosis and AF. Can we use a heart rate controlling agent in patients with mitral stenosis and normal sinus rhythm? Yes, it can be used because they have tachycardia, and whenever the tachycardia happens on activity, the gradients increase. So heart rate controlling agents can be used in patients with mitral stenosis and normal sinus rhythm. Prosthetic valves. The initial transthoracic echo is recommended in all patients after prosthetic valve implantation for evaluation of hemodynamics. This is very important because this is going to be the comparative data when you follow these patients in your clinical practice. The choice of type of prosthetic heart valve should be a shared decision-making process that accounts for patients' values and preferences and includes discussion of the indication for and risk of anticoagulation. Why I'm reading this is nowadays we are seeing patients who get bioprosthetic valve at the age of 40, 35, 30. And because there was a patient, just 25-year-old, he underwent a bioprosthetic AVR because he did not want to consume warfarin and he wanted to live an active life. He was an athlete. So it's very important that patient and patient's family should be involved in the decision making. Modified, what is the new thing? An aortic or mitral mechanical process is reasonable for patients less than 50 years of age who do not have a contraindication to an anticoagulation. So again, for patients between 50 to 70, it should be a shared decision. I think we can skip all these things. So anticoagulation with vitamin K and INR monitoring is recommended in patients with mechanical prosthetic heart valves. So for AVR, who have a mechanical aortic valve and additional risk factors for thromboembolism, the target INR is 3. For mechanical mitral valve, it is 3. But if there is a mechanical aortic valve and no risk factors, the INR of 2 to 2.5 can be maintained. Aspirin, it is required for all patients who have a mechanical heart valve. So aspirin plus oral anticoagulation both should be administered to a patient who has a mechanical heart valve and not only acetylcholine or warfarin alone. This is again, we can skip this. There's a new type of aortic valve where you can achieve a target INR of 1.5. Anticoagulation therapy with oral direct thrombin inhibitors or anti-10A agents should not be used in patients with mechanical valve prosthesis. That means the NOACs should not be used in patients with mechanical heart valves. Bridging therapy, again very important. You already heard the talk about bridging in CAD patients. Let me just ask a question. How many of you stop aspirin if your patient is undergoing cataract surgery? So look at the new recommendation. Continuation of vitamin K anticoagulation with therapeutic INR is recommended in patients with mechanical heart valves undergoing minor procedure like dental extraction or cataract. So if patient is undergoing a dental extraction or a cataract, the acetylcholine or warfarin should be continued and the therapeutic INR should be maintained. Temporary interruption of vitamin K anticoagulation without bridging agent while the INR is subtherapeutic is recommended in patients with bileaflet mechanical valve. So it is important that in your records you know what type of mechanical valve was implanted. Bridging anticoagulation therapy during the time interval when the INR is subtherapeutic preoperatively is reasonable. So sometimes you encounter in your clinical practice what to do if you are stopping warfarin. Should you put them on low molecular weight heparin irrespectively? So if patient, I'll come to those slides. Again, if patient has a bleeding, FFP is required to stop the bleeding. But this is important. If patient has a mechanical valve, mitral valve in place, the target INR is 3. If vitamin K therapy is interrupted for non-cardiac procedures, bridging should be done. So mitral valve, it has to be done. Aortic mechanical valve with risk factors, it has to be done. But if patient has an aortic mechanical mitral valve and there is no other risk factor, and patient who had therapeutic INR prior to the surgery, no bridging is required. And immediately post-procedure or post-surgery, you can restart the anticoagulation. Here, the only thing which I would like to stress, if you are following a patient with mechanical or a bioprosthetic valve in situ, and now he comes with new diagnosis or new symptoms of heart failure and fever, first suspicion should be an infective endocarditis, and before administering an antibiotic, you should send this patient for 2 blood cultures and then start an empirical antibiotic. Pregnancy, again a very mechanical valves and pregnant patients, again a very important clinical dilemma which we encounter in clinical practice, but let us go to the important ones. Valve operation should not be performed in pregnant patients with valve stenosis in absence of severe heart failure symptoms. So if you are following a patient with who's a pregnant lady and has valvular pathology, but it is asymptomatic, we don't do anything, just continue following them. We know that ACE inhibitors ARB are not administered. Therapeutic anticoagulation with frequent monitoring is recommended for all pregnant patients with mechanical prosthesis. Warfarin is recommended in pregnant patients with mechanical prosthesis in 2nd and 3rd trimester. We all know this. But what about the 1st trimester? And again, aspirin should be continued. So I'll just come to the important slide here. The low molecular weight heparin should not be administered to pregnant patients with mechanical prosthesis unless NT10A levels can be monitored after administration. This is now class 3 and it can cause harm to the patient. So first trimester, this is what I would like to focus. If the patient is pregnant, has a mechanical valve, is in the first trimester, you look at the dose of warfarin required to achieve that target INR. If the dose of warfarin is less than 5 milligram per day, the warfarin can be continued in the first trimester also. But if the dose of warfarin is more than 5 milligram to achieve the target INR, then it should be discontinued. So earlier in the previous guidelines, warfarin had to be discontinued in the first trimester. Now, if the dose is less than 5 milligram, it can be continued. Thank you very much for your kind attention. I would continue with my second talk also. Okay. Yeah. So you want me to summarize the valvular guidelines? Yeah, no, it will be very short. So I've got instructions to finish this in 15 minutes, maybe 10 minutes. TAVR moving from high risk to intermediate risk to low risk. So TAVR stands for transcatheter aortic valve replacement. This is my favorite slide. Some people in the audience, my colleagues, may be laughing because I show this slide every time. And this is the 5-year survival rate comparing between breast cancer, lung cancer, colorectal cancer, prostate cancer, ovarian cancer, and severe inoperable aortic stenosis. So look at the 5-year survival rate, 3%. It is less than various other malignancies. And aortic stenosis, as we all know, has a long latent phase. There's a prolonged asymptomatic phase, but once the symptoms begin, there is a rapid downhill course. And this slide clearly shows that medicines don't work in aortic stenosis, and if patient has symptomatic severe aortic stenosis and does not undergo an aortic valve replacement, 50% of them will die at 2 years. And there's 2% per month mortality in these patients, and 1/3 of patients with severe aortic stenosis do not receive treatment. What does that show? That there is no medical management of aortic stenosis, medicines don't work, and it is a killer disease. Patients die from it. So earlier, when the TAVR started, that is valve replacement without open heart surgery, it was initially studied in high-risk patients because whenever a new therapy comes, you need evidence to practice it. So in the high-risk trial was the partner trial and the US core valve high-risk registry, where it clearly showed that TAVR was not inferior to open heart surgery. Now we have almost 5-year data. So if you look at the 5-year data from the partner 1A, where everybody was very high risk for an open heart surgery. So if patient is high risk for an open heart surgery, he is high risk for all other outcomes. So if you see, these transcatheter valve was not inferior to surgical AVR. And if you look at the survival, the TAVR patient survived longer than the surgical AVR patient. Again, the stroke rate was equivalent. And it clearly showed when compared to medicines alone, TAVR improved the survival as well as the symptoms. And the number needed to treat to save 1 life was just 5. So if you do 5 TAVRs, you save 1 life. Do you know what is the number needed to treat in a primary PCI? 17. If we do 17 primary PCIs, we save 1 life. So the TAVR has more stronger and robust evidence than any other trials. So TAVI is equivalent to surgery in high-risk patients. This we already saw. What about the intermediate risk patients? Again, there's enough evidence, the partner 2 trial data, compared patients who were intermediate risk for open heart surgery and randomized them into open AVR and a transcatheter valve. Surprisingly, the TAVR was superior than an open heart surgery with P-wave value of 0.04 when it was done via femoral artery. And the all-cause mortality and stroke were similarly to the open heart surgery. So all these trials led to the US FDA approval of transcatheter aortic valve replacement in patients who are high risk and intermediate risk in 2016. What about the low-risk trial? Notion trial. Notion trial, what it did, it randomized all patients above age of 70 years with aortic stenosis into 2 groups, open AVR and transcatheter AVR. And the valve which was used was self-expanding valve, and the TAVR was not inferior to surgical AVR at 1 year. Now we have 5-year data from the Notion trial, and the TAVR is better than a surgical AVR in terms of mortality, stroke, atrial fibrillation, and kidney injury. This is what I just I was downloaded from on my iPhone and transferred here. What about low-risk patients? See, this is published in October it's still in publication, the transcatheter aortic valve replacement in low-risk patients with symptomatic severe aortic stenosis. And I want to draw your attention at this. At 30 days, there was 0 all-cause mortality in patients who underwent TAVR versus 1.7% mortality in persons who underwent surgical AVR. There was 0 in-hospital stroke in patients who had transcatheter aortic valve replacement versus 0.6 stroke in surgical AVR. Pacemaker implantation rates were similar. And why the pacemaker implantation rate were higher in the high-risk trials? Because, as I said, all those patients were high risk for all outcomes. And so now there is a randomized trial. The data will be coming out in next 6 months, which has enrolled all patients irrespective of the age group. So the future, anybody who's a candidate for bioprosthetic valve will be a candidate for TAVR. So this is the whole spectrum of patients which we see with aortic stenosis. You have a low-risk patient, intermediate-risk patient, high-risk, extreme-risk. We have data in all spectrum of aortic stenosis, and TAVR is moving robustly. One important question which we encounter is, how long does the valve last? Is this valve going to last as long as a surgical AVR? We have enough data that this valve lasts as good as this open heart, the surgical valve, with, in fact, lesser gradients and better aortic valve area. And this is just a slide which shows the mortality is directly related to the STS score, because as the score goes up, the mortality goes up, and that is not because of the TAVR procedure, because these patients are high risk for any sort of outcomes. There is just like a high risk protoplasm in them. And with this, the TAVR is definitely going to increase, and these are the global numbers which are predicted. This is a slide from TVT 2016, and India also, it is robustly moving. Just sharing how it is moving. In India, the mean age is almost 74, 73, and why the mean age changes compared to the Western population depends on the survival and various other socioeconomic factors which play a role. So 74-year-old female had bicuspid aortic valve, severe AS, normal LV function. And we do CT scans to plan these procedures, and this is how the valve replacement is done. This is the femoral angiogram. We look at the valve, cross the valve, do a balloon dilatation, and position the valve, and the new valve is placed in place. These patients, they go home on 4th day post-procedure. The average hospital stay is just 4 to 5 days at EHCC. Similarly, I'm going to skip all these things just for the interest of time. I still have 8 minutes, 3 more minutes. So these are just diagrams that how you can just appreciate there is no breathing tube in place in some of these patients, and everything is done under conscious sedation. This is just an example of another very complex patient with severe AS and severe CAD with a left main disease. So yes, an angioplasty and a valve replacement both can be done in the similar setting. Like in this patient, we did an angioplasty, PCI to the left main, and valve replacement, both without open heart surgery in the same setting. And this patient was discharged home on 4th day. And this is how the valve looks like in place. And this is a bioprosthetic valve. Look at the mean gradient on follow-up. Mean gradient is just around 4. And these patients, now she has completed almost 1 year of follow-up. I'm going to share our EHCC experience. We have completed 56 cases. We are one of the centers in the entire country to use all types of valve. We have used Evolut R, Sapien 3, MyValve, Core Valve, and we have also done transcatheter mitral valve replacement. The mean age is around 73. Except for one, all 55 patients were done under conscious sedation. All 56 patients are done under percutaneously. There is no surgery, no cut down here. One of the patients had a stroke, which we treated on table. Our average hospital stay comes around 3.4. There is 0 30-day mortality. One patient died at 6 months because of sudden cardiac death. She died after 3 months of TAVR in the toilet. And coming to the conclusion, TAVR is now proven in patients at intermediate surgical risk, which is already FDA and CE approved. Currently, there is a significant clinical investment in applying to the technology in order to move to the younger patients. Because if we are doing a TAVR in younger patient, we should be able to replicate our results to a surgical AVR with no PVL and minimal pacemaker rate. It is possible that TAVR will provide an alternative therapy for patients with moderate aortic stenosis and a heart failure. for the interest of time, I didn't go into it details, but there's a trial which is ongoing in patients with asymptomatic severe aortic stenosis. And the idea is you open up the valve, treat it before irreversible changes develop in the myocardium, like fibrosis and stiffening. Overall, the future of transcatheter valve therapy is incredibly bright, with an expected number of 3 lakh patients served annually within the next 10 years. And this number is the European number. In India also, it is robustly increasing. Now almost close to 500 TAVR procedures have been done in past 5 years. And in the last 1 year at EHCC, we have been leading from the front. Thank you very much for your kind attention. I finished 5 minutes before my time.
Yeah, we can quickly move on to the next ECG quiz, very in a summarized way, for 10 minutes, just 10 minutes.
Anyone who is interested to ask Dr. Ravinder about TAVR or any clinical decision making regarding valvular heart disease? So I think we can conclude this session. Thank you very much, chairpersons. You can take your seat. I think those who have been sitting here till this time, they are really interested in ECG, so we cannot skip that session and we have to take that. I think for that I will invite Dr. Prem, you can stay back. Dr. Sanjeev, stay back. Dr. C.V. Meena sir, please come on the stage. Dr. Atul Kasliwal. Yeah. Yeah. So, Dr. Kush. Yeah, so what we'll do is we have quite a lot of ECGs. So what we'll do is we'll choose 5 ECGs of acute coronary syndrome, or maybe 3 each, and then if still people are interested, we can show a couple of more. So I think this should be an interactive session, so why not everybody can come ahead here on these